Hi everyone, my name's Stephen Belgeri with the Webster Groves Fire Department, and today we are going to be going over CPAP. We will be talking about indications, contraindications, where it lies in treatment protocols, and we will be going over the procedure for applying it. But first we need to find out where it is. In the ambulance, there's two locations for it. We have in the jump bag. So what we'll do is we'll pop the tag off here. Remember, always replace the tag when you're done. And here we have it right here. Inside the CPAP bag is going to be an end-tidal nasal cannula. That's going to be important for when we go over applying the CPAP. We also have another unit in the ambulance right here. Packaged the same way. All right, so now we're going to go over the indications and contraindications for CPAP, and then we'll talk about the procedure for applying it. So obviously CPAP is very important in the respiratory protocol. It's going to be for the moderate to severe patients, and the goal of it is going to be to avoid intubation. The main people we're going to be using this on are going to be COPDers and patients with pulmonary edema secondary to CHF. As far as contraindications go, any patient with altered mental status, if they have facial deformities and will be unable to form a seal, or if they have excessive secretions, we're not going to be able to use CPAP for those patients. We're going to want to consider probably intubation. Everything we need we got right here. You're going to need an oxygen bottle. The first thing you want to do is obviously explain what you're doing to the patient. Most of the patients we run have had CPAP before and can tolerate it. If patients can't tolerate CPAP, protocols do allow us to try a low dose of 1 milligram of Ativan, try to relax them and they can tolerate better. It does cause a little bit of claustrophobia, but we'll want to apply the end-tidal nasal cannula first. That way we can monitor respirations and end-tidal once we put the CPAP on. So end-tidal monitoring can tell us a lot about how well the patient is actually moving air. Obviously, if they're having higher levels of CO2, that means that they are having a difficult time blowing that out. Most of the time, that's just due to the poor elasticity due to lung tissue disease. COPD, the reason we're putting them on in the first place. So even just putting them on end-tidal can often tell you how bad they need CPAP. And our goal is once we put them on and we can help inflate those lungs, they'll actually be able to exhale some of the CO2 that's trapped in their lungs. So for the portable oxygen bottle, we connect right here. It just screws on, and we set it to 25 liters a minute. And we're going to apply the mask to the patient's face. You're obviously going to want to be talking them through it. So we want to come over the top of their head. And at this point, you can be holding it to their face and create a seal and attach the hose. And the patient can start receiving their treatment while we are still securing the mask to get a good seal. And now that we have a seal, we can set the PEEP. So protocols dictate that for COPD emergency, you want to start at a PEEP of about 3 to 5. And for pulmonary edema, you want to start at a PEEP of 10. You set it by just turning this dial. And you can turn it, that would be 10. So where this arrow points is what your PEEP's going to be. And so you can start, we could put a patient on 5 if they're having COPD emergency. So basically, to keep it simple, dry lungs start at 5, wet lungs start at 10. And you can always go up if you need to as tolerated. Okay, so some patients, when we put them on CPAP and we're not seeing the improvement that we want, we can administer nebulized medications. This connection right here is where we would hook up our nebulizer kit. We would need a second bottle of oxygen. We will squirt the Prevenal and Atrovent into here, and you want to set the oxygen bottle at 6 liters per minute because that creates, that aerosols it the right amount. And once you do that, you just simply connect the nebulizer right here, and we have oxygen flowing at 6 liters per minute, and the patient can get the benefits of CPAP from positive end expiratory pressure as well as the benefits from the medication, and we can hope to see an improvement from there. So when we have the patient on CPAP, the improvements that we're going to be looking for are obviously SpO2 of 94% to 99%, as well as hopefully bringing their end tidal CO2 in range, which we like to see between 35 and 45 millimeters of mercury. We'll be assessing lung sounds. Most of these patients that need CPAP are going to have diminished lung sounds. So if we can hear a little bit more clarity, that's great, as well as a little bit more volume. And it's also important to remember that the full benefit of CPAP does take approximately 3 to 5 minutes to achieve, to actually reinflate the lungs and get those alveoli open. So if your patient isn't improving after a few minutes, just give it some time before you decide to take the treatments elsewhere. Indications. These are going to be respiratory patients. They're going to have decreased lung sounds or significant wheezing. A lot of them will have a history of COPD or CHF. Contraindications are going to be patients that cannot follow commands or altered mental status, as well as facial deformities or significant oral secretions. And to keep it simple for setting the positive end expiratory pressure, if they have dry lungs or a COPD exacerbation, we're going to set it to 5. If they have wet lungs or a CHF exacerbation, we're going to set the peak to 10.